We are live.
Good evening. Welcome to Aios International Masterclass. Every fourth Saturday, we have the International Masterclass program, and today we have none other than Professor Dua, who is India's pride. This slide I show in every quiz of mine. Pehle panch the, and Dua gave us the sixth. That is the sixth layer of cornea. Rashmi will introduce him in detail and his topic. But let me introduce the chairpersons, Dr. Samar Kumar Vasak, who is a cornea specialist from Disha Eye Hospital, currently the president of Aios. Professor Radhika Tandon from RP Center for Ophthalmic Sciences will co-chair with him. We have the moderator, Dr. Rashmi Deshmukh, who is a fellow of Professor Dua himself, currently from LV Prasad Eye Institute, Hyderabad. And the other expert panel would consist of Professor Bhavna Sharma from AIMS Bhopal, Dr. Beena Kulkarni from University of Nottingham, Dr. Geeta Behra from JIPMER, Pondicherry, Dr. Josephine Christie from Arvind Eye Hospital, Pondicherry, Dr. Manisha Acharya from Shroff Charity Eye Hospital, Delhi, and Rajesh Fogla from Apollo Eye Hospital, Hyderabad. We have young ophthalmologists who will be presenting cases. Anusha Churi from Arvind Eye Hospital, Puducherry, Beena Kulkarni, of course, from University of Nottingham, Dr. Dennis Pincus from Mexico, Dr. Jayashri from JIPMER, Pondicherry, Isha Chaudhary from Shroff Charity Eye Hospital, Delhi, and Manu Murali Krishna from RP Center for Ophthalmic Sciences. And that's the program. I hand you over to Dr. Rashmi Deshmukh for further proceedings.
Thank you so much, Dr. SH. I'm just going to try and share my screen.
You're on.
Is my screen visible?
Yes.
Yeah. So it gives me immense pleasure to introduce today's guest speaker, Professor Harminder Singh Dua. I don't see a more appropriate situation where I can say that he needs no introduction. I'm just going to minimize this, sorry. So he is the chair and professor of ophthalmology at Queen's Medical Center, University of Nottingham since 1994. And he's been a president of several societies like Royal College of Ophthalmologists of UK, of Cornea, of the European Association of Vision and Eye Research, that is the EVA, and of the EVA Foundation. He was also the editor-in-chief of the British Journal of Ophthalmology from 2007 to 2014, and the Journal of Cornea as well. Apart from that, he's an honorary professor at Università della Svizzera at Lugano since 2010. And also he's an honorary professor at the Research University Institute of Ophthalmology at Cairo since 2024. So amongst his remarkable contributions in ophthalmology, we all know the Dua's classification for chemical injuries. We are all aware of the fine needle diathermy for corneal neovascularization. We also know about the sequential sectoral conjunctival epithelectomy for corneal conjunctivalization, PDEC, and then ACER for limbal stem cell deficiency. And the most remarkable contribution to ophthalmology, like Dr. Santosh Navar was just mentioning, was the discovery of the sixth layer of cornea, the Dua's layer, which is named in his honor. The impact of his contributions can be summarized by just this figure, which I've got from Google Scholar, where the citations are more than 30,000, and he has an H index of 84, which is almost the highest of anybody that I've seen, at least till now. Apart from that, he has also been appointed as the commander of the Most Excellent Order of the British Empire by Queen Elizabeth II in 2019. And he also served a full term as the High Sheriff of Nottinghamshire from 2021 to 2022. And he, apart from all of that, he has NHS Parliamentary Lifetime Achievement Award to his credit for the Midlands. And the other high honors that he's received is the Rotary Foundation Global Alumni Service to Humanity Award, the Times Higher Education Award for the Best Research Project of the Year in 2014 for his work on Dua's layer, and the Melvin Jones Fellow Award Lions Club International Foundation for the humanitarian work. He has supervised more than 55 PhD students and multiple fellows every year. This was one of my pictures with him during my fellowship. It was a wonderful time. And he also balances his professional and personal life very well. And this is a family picture that he had kindly shared. With that, I would like to hand over to Professor Dua now. And his topic today is a very interesting one. It is paradigm shifts in understanding corneal pathology through corneal anatomy with implications for management. So I'm going to stop sharing.
Yeah. Before that, and if Dr. Sama Basak is online, I would request him to make the opening remarks. Dr. Basak,
Yes,
request you.
I'm sorry, little late because of no current here.
No.
So, welcome, sir, in this international master class, and it is your subject, and we have learned a lot of things from you today. There will be more learning from you, and it will our pleasure that all the members of Aios and also abroad will be helpful from your talk. Thank you very much, and please go ahead with your talk.
Well, thank you very much. While I upload my talk, may I mention that it's really an honor to be in such illustrious company of the president of Aios, Dr. Professor Basak, Santosh Honawar, Radhika Tandon, and of course, our very own Rashmi. Thank you all for this privilege. Now, I want to minimize this here so that it doesn't obscure my slides. I hope the introduction that Rashmi gave, that time allocation was not part of my time allocation, because she was very generous with her remarks and comments. Thank you for that, Rashmi. You've already mentioned the title of my talk, which is here. Moving on, we know that corneal anatomy influences corneal pathology. Concepts of corneal pathology change as our understanding of anatomy improves, and when we alter anatomy, phenotypes of clinical manifestations change, especially in the cornea. I'm going to give you examples of epithelial pathology, stromal pathology, and then, of course, a major portion of the time will be on posterior corneal pathology, where I hope to be able to convince you that simple conditions that we took for granted are not what we believe them to be. Now let's look at some epithelial examples. We see this condition hurricane or vortex keratopathy. The hurricane is the name of the shape of a hurricane as depicted on a weather map. And the same one we see here in vortex keratopathy, which is due to deposition of materials, or in this case, iron. This clockwise whirl pattern, which we noticed this is in corneal grafts. This is this from one of my patients, but this was the first description of hurricane keratitis given by Pollock and Sidders on the basis of what they saw in corneal grafts, and they said it is exclusively limited to corneal grafts. And here's a patient with a CIN, an intraepithelial neoplasia, where also the cells are tending to form a whirl. We noticed that this was almost always clockwise, so there must be an explanation for that. And we gave this explanation with the help of Dr. Mathur, who's a physicist from Canada, and he helped develop this theory that the eye is a dipole, the current flows from the front to the back, hence you will get, with the right-hand rule, you will get this clockwise distribution of electromagnetic fields, and the corneal epithelial cells respond to electromagnetic fields. We know they respond to electric fields per se. They have this galvanotaxis or move towards the cathode. So all that was adding together, and that was the explanation we put forward. We put some cells in culture in magnetic fields, and we were able to form or reproduce this whirl pattern in the magnetic fields as well. But then we started learning more about corneal nerves, and we know the subepithelial plexus, it comes from substromal nerves, which give out these fine neurites, and these neurites then form a plexus, which we know as a subepithelial plexus. And this is some work from Marford, who showed that these nerves, which are in the subepithelial plexus, then actually go into the epithelium and terminate within the epithelium, either intra or intercellularly. And by using the acetylcholinesterase techniques, Dr. Akaba in our group here showed that you can show that whirl pattern in the subepithelial plexus in human eyes. And the same was very nicely reproduced by confocal microscopy. So here we have two anatomical situations. The epithelium, which forms like a whorl, that whorl is only highlighted when the epithelium can be visualized with the deposition of material in it, or when the turnover is so fast that fluorescein outlines the cells that are moving. But here you can see the nerves also form exactly the same whorl pattern. And because we know that the subepithelial plexus is intricately attached via these intraepithelial nerves to the epithelium, then the two work as one unit. Now, whether the epithelial whorl is causing the whorl pattern in the nerves, or is it the nerve whorl pattern causing the whorl pattern in the epithelium, or whether it is the electromagnetic fields causing the same in both. So here you can see how structure function is related to the basically the anatomy is determining patterns of disease such as hurricane keratopathy that we see in some of our patients. Sometimes pathology can alter anatomy, as here we see in keratoconus, sticking to the nerve theme. The apex of the keratoconus, or actually in the cone of the keratoconus, the nerve morphology is extremely altered. In the more advanced cases, the more it is altered. And interestingly, this is, of course, corneal nerve pathology. But if you look at the subbasal plexus, which forms this very characteristic concentric pattern along the base of the cone. Now, that is not normally seen, this concentric distribution of subepithelial nerves. But what you're having is that an altered shape of the cornea, that altered anatomy is determining the adaptation of the other structures around it, which are quite normal. This is a very interesting other observation. If you acutely change corneal anatomy, for example, by having very tight sutures and making a mark with the rule astigmatism, you get epitheliopathy, whether it's due to dry eyes, whether it is due to the large neurotrophic defect you may have created by these large incisions we used to do for extracapsular cataract extraction, or even with limbal relaxing incisions, what you see is this epitheliopathy. And the interesting part of this epitheliopathy is that it can be relieved by taking out the stitches and getting the shape back to normal. Now, that is a less known fact, but it is very interesting and important. Now, here is an example of the same thing happening in a patient with a corneal graft where the horizontal sutures have been removed. The vertical sutures are in place, causing very steep with the rule astigmatism. And there you have an epithelial defect, almost about between 50 and 60 diopters of alteration in the anatomy of the cornea by compressing it from above and below. And you can see that staining area. And all we have to do is, you don't have to go and putting all drops and insulin or nerve growth factor or amniotic membrane, none of that. Just take these sutures out and this thing heals. So it's telling you that altered anatomy can cause pathology, which you may think is due to a number of other conditions, which may be contributing. The neurotrophic effect of nerve transaction in the graft, especially all around, and the dryness caused, etc. And in this example, where the same thing is happening, we would attribute this to the use of either non-steroidal anti-inflammatory drugs or to the underlying rheumatoid, but not to forget that altered curvature you have created acutely with tight sutures, which can also be a factor. And therefore, keep that in mind when you're dealing with such patients. And if there's a reason to believe that that is the case, then go ahead and take the sutures out. Another example where we are now overlapping stromal and epithelial pathology, we know about granular dystrophy, where you have this granular material deposited in the epithelium and in the stroma. They get recurrent erosions, glare, and visual problems. Interestingly, when you do a corneal transplant, be it a DALC or a penetrating graft, the recurrence of disease occurs in the epithelium. Now, when it occurs in the epithelium, then you have a problem, because the longer it stays in the epithelium, the more goes into the anterior stroma. we know from various studies that epithelial turnover usually happens in 2 to 3 weeks, but not all the cells, because we can still get epithelial rejection following a DALC or a PK operation a year after the operation. Hence, probably the entire epithelium is replaced in a year. And that's when the host epithelium starts to come in with the granular gene defect in it. You start getting these deposits. And we know that the keratocyte turnover takes 2 to 3 years. So recurrence of granular deep in the stroma occurs later, but from the epithelium into anterior stroma, it can occur earlier. So understanding that anatomical basis of new cells migrating from the donor, from the host epithelium onto the donor, one can come up with a treatment strategy, which is this. So here are the examples of patients. This was Dr. Avadanam, who was working with me and published in ophthalmology. So before the epithelial deposits start to encroach into the anterior stroma, you do alcohol delamination of the epithelium, and the epithelium heals and becomes very clear. These are confocal images showing the deposits intraepithelially, and these are the low power transmission electron microscopy showing the deposit of the material within the epithelium. So you keep taking it away, and you can give the patient relief from his symptoms of erosion, as well as restore the visual disturbance they experience from these deposits. The important thing is that you can, well, this is a little video of alcohol delamination, just to show you what we do. Everybody knows this. I'll probably just skip this because everybody knows how to do that. But what everybody doesn't know is what comes here. What do you do with that epithelial sheet that you remove? What you do is you spread it on a piece of paper with a drop of balanced salt solution. You literally float it on it, open it, then you absorb the water from all around it. Then you put your formalin or glutaraldehyde or alcohol or whatever fixative you want on acid, then it fixes absolutely flat. And this is particularly true for patients where you suspect CIN, because the pathologist can give you beautiful orientation from the basal to the anterior surface. And you do this with the fixative for about 10 to 15 minutes, and then you put it in the solution and send it for histology. You get excellent results. So that's very important tip for alcohol delamination. So when you do that for these patients with the recurrence of granular dystrophy, you can see that we have follow-up going up to 15 years, and we have done this alcohol delamination several times, and in not one of these patients, we had to repeat a cornea transplant, which otherwise would have had to be done very quickly because of the problems the patient gets with recurrence. So you can avoid a repeat cornea graft, whether it's anterior lamellar or full thickness, for up to 15, 20 years or more, until when the stromal density increases, and then you have to go into a full thickness or a lamellar graft. I told you about iatrogenic planes that we create, alter the phenotype of clinical pathology right in the beginning. And here's a DSEC plane. The DSEC plane that we create is completely new to the cornea in terms of the stroma. It's a completely different anatomical plane. Infections tend to spread along these planes, as do blood vessels, as I'll show you. So here's intense. You can see the infiltrate is only in that plane that we have created. We know this for LASIK flaps, sands of Sahara, lots of things now manifest differently because of the altered anatomy of the cornea that we have created. Here's another interesting example of a DSEC. There was infection at one end, and there was the infiltrate in the plane, but the vessels that were coming from the other side of the same eye, you can see, are exactly in the interface plane, where most of the chemokines are now spreading more easily across the plane and causing the vessels to come from the other side. Blood vessels do exactly the same. If we create new planes with suture tracks, you will find blood vessels will go along that predominantly and preferentially in penetrating grafts, and then along the graft host junction. But in deep anterior lamella, we've given them another plane at the interface between the donor and the recipient, and there they suddenly fan out because there's less resistance. So these planes are altering the manifestation of corneal pathology. Again, the same point that anatomy does determine pathology to a huge extent. Now, coming on to stromal pathology, we have seen about infectious crystalline keratopathy. We all know that this crystalline Christmas tree type branching pattern in the stroma of individuals where the host inflammatory response is suppressed. And this was largely seen in corneal grafts and was believed to be due to the high dose of steroids we use to suppress the host inflammatory response. But I submit that it is more than that. It is largely seen in eyes where the corneal innervation is affected by your surgery, and the local antidromic response, the local nerve reflexes that we have, which allow vasodilation and influx of cells, that is gone. Hence, the bacteria grow without the host response. But the shape they take, this crystalline shape, was attributed or is still attributed to biofilms produced by these organisms. But I submit that it is due to the stromal architecture more than anything to do with a specific organism. And let me just take you to this image when we're moving on towards the posterior stroma. When you inject air in the cornea, and the cornea is quite deturged, you see this crystalline pattern. Exactly those cracks in the glass, those line-like patterns appear. Movement of air determined by the microarchitecture of the corneal stroma. And this is recent evidence, but in the past, we proved this by a different approach. What we did is we took eye bank corneas and we inoculated them with the same organism. One cornea was deturged, the other was allowed to stay in a swollen state. And you can see the same organism produces that beautiful crystalline pattern if it is deturged and compact. But if it is swollen, you only get globules of bacterial colonies, and histology shows these bacterial colonies. Of course, these were eye bank eyes, so there's no question of a host inflammatory response. So it is the microarchitecture of the stroma that is determining the pattern of microbial spread, but we can't normally see it because the host influx of inflammatory cells causes a purulent infiltrate response, and this pattern is masked. Now, moving on to the back of the eye, we're going to look at the pre-Descemet's layer associated pathology and then with the Descemet's membrane, briefly touch on something new about the Descemet's membrane. So understanding posterior corneal anatomy in the context of the pre-Descemet's layer has led to novel insights on various corneal pathologies. Now, to understand this, I'm going to make three basic comments, and then we will go on to the pathology. The first is that whenever you do OCT of the cornea, the Descemet's membrane always appears as a double parallel line, a tram track, or a double line like this, where the posterior surface is hyperreflective, so the anterior and the posterior both. So remember that OCT is giving you changes in refractive index, which often correspond to histology, but they are not histopathological changes. Where the interface between the low density and high density is there, you get a hyperreflective line. Then the dark line in between is the structure, the substance of the Descemet's membrane. And then the other hyperreflective line is again the interface between the anterior surface and the aqueous. Now, this is not due to endothelium. It is due to either endothelium. If you take the endothelium away, you still get this double contour line. And this was also shown by ultra-high resolution OCT by Bizeva from Canada, that you get this double contour line. Then you have the last row of keratocytes, and in between, this was their paper was emphasizing the first in vivo demonstration of the pre-Descemet's layer corresponding to the histology by ultra high resolution OCT. That's the first point. The second point is we all know about these, but notice the circular movement of air. We all know about the different types of bubbles now. This is a type 1 bubble. It occupies the central 8 or 9 millimeter, leaving that space where the air doesn't go and the predestined layer is not lifted off. If you look at a type 2 bubble, again, notice that circular movement at the periphery, then the formation of the bubble, which occupies the entire posterior surface, air collecting in front of the desmus membrane that we see over here. Now, just to digress for one slide from the main theme, when you see this air moving in this circular direction at the periphery, we see this when we do DALK as well. Often it makes a circular movement. Why is this so? What is happening over here? And of course, everybody's curious to know, why does it consistently go in a circular pattern? You're depositing air here, it moves quickly to the back, reaches the limbus, moves clockwise, anti-clockwise, and then they meet to form that circle. And then the air starts to come centrally to form the bubbles. Interestingly, this is maybe a coincidence, maybe not, that if you do this section over here and you see this, that part is much more loose. It's supposed to be the thicker and more compact part of the cornea, as we know anatomically, but that's the part that gets filled with air much quicker and much more than the one in the center. And these are two different patients. But even more interesting is the fact that this part here, and this is a scanning EM picture where the bubble marks the point where the bubble will end. This inner part of this circular movement marks the point up to which the type 1 bubble will be formed. And this part over here is the thickest part of the cornea where you see this aeration occurring. The desmus membrane has been cut off. But even more coincidentally or interestingly, that's the part of the cornea where it is the flattest in the prolate shape of the cornea, which you see at the periphery, the 1 to 1.5 millimeter of the cornea, giving it that prolate shape, is determined by that part where the air moves, where the predestined layer is firmly attached beyond the edge of where the bubble forms. And on topography, we see that same again at the periphery is flatter. So whether this relates to the peculiar behavior of the peripheral cornea. See, when you do incisions in the extreme periphery of the cornea, you do very little induced astigmatism. The more central you get, the more is the induced astigmatism. If you do incision in the periphery, you don't. We know peripheral ulcerative keratitis tends to migrate more circumferentially. For whatever reason, we know that it occurs at the periphery because that's where the immune cells come from, the limbal blood vessels and the conjunctival blood vessels. But why does it then, once in the cornea, tend to have a preferential circumferential spread? Is it related to this peculiarity in the anatomy or not? We don't know, but it's an interesting coincidence. Now, getting back on track with the theme, that we talked about type 1 and type 2 bubble, and we know there are mixed bubbles like this, where you have the central type 1, the peripheral type 2, as you see here and here as well. So those were two comments. And the third comment is that there are strands that extend from the back of the cornea to the anterior surface of the predestined layer. These strands are easily separated in the center, but as you go to the periphery, they're quite attached. And sometimes one has to separate them physically. And those strands, as they break, they give you this rough appearance of a type 1 bubble in the DALK procedure and a very smooth appearance of a type 2 bubble, because the anterior surface of the desmus membrane does not have any connection with the posterior surface of the predestined layer with strands. Those strands only exist between the anterior surface of predestined layer and the posterior surface of the deep stroma. Now, with these things in mind, let's look at posterior corneal pathology, because this just wanted to give you this refresher to help understand what I'm going to say next. What is the definition of desmus membrane detachment? It's a detachment of the desmus membrane. And this was first described in 1928, almost 100 years ago. and is also the most recent definition, if you see in literature, even in 2024, is that. Now, what I'm going to tell you is that this is not true. We have demonstrated on the basis of the pre-Descemet's layer as part of the microanatomy of the posterior cornea that Descemet's membrane is not what we have thought for almost 100 years. What happens in Descemet's membrane detachment is exactly the three types of bubbles. You get the type 1 Descemet's membrane detachment, which is made up of the pre-Descemet's layer, Descemet's membrane, and the endothelium. A type 2 detachment, which is made up of endothelium and the Descemet's membrane, and a mixed where you have a combination of the two. Now, these are OCT pictures of Descemet's membrane detachments of the eye. You'll see where there is a straight line, like a chord of a circle, occurring predominantly in the central 8 or 9 millimeter of the cornea. A taut line like that is a type 1 detachment because the pre-Descemet's layer has also detached together with the Descemet's membrane. Where you get this double contour line, wavy line, it's not a straight line, can be anywhere across the entire posterior surface. That's a type 2 detachment. And when they are torn or detached, they scroll with the endothelial cells outside, and then we call it a regmatogenous type 2 detachment. Or it can be a type 3, or we rather call it the mixed, like the bubbles, where both have separated, the pre-Descemet's layer and the Descemet's membrane, but they've also separated from each other, unlike over here. So it's like a mixed, a big bubble. You know, the type 1 component is the pre-Descemet's layer separating, and the type 2, which is wavy, is the Descemet's membrane separating. And these are patients with Descemet's membrane detachment. Now, let's look at this patient. 5 months after cataract surgery, cornea is not clearing. Slit lamp, straight line, chord of a circle, OCT, straight line, chord of a circle. You do histopathology of this, you will see there's a pre-Descemet's layer and the Descemet's membrane. That is very important for treatment. Here, we have done the histopathology, and you can see an acellular pre-Descemet's layer with keratocytes on the surface, and then the banded and non-banded layers of the Descemet's membrane over there. On histology, on slit lamp, straight line, on OCT, straight line. Here again, you can see another patient, persistent corneal edema post-surgery, straight line is the pre-Descemet's layer component, and the Descemet's membrane is separated and torn and curled up, so it's got a mixed Descemet's membrane detachment, which is regmatogenous for the type 2 component. Here you can see there are two lines. Again, a type 1, much straighter line, a more wavy line is the type 2, is the Descemet's membrane, and so on. This was a patient with a cornea transplant, which had failed, and the endothelium had completely gone. We did histopathology here as well, and you can see that straight line of the pre-Descemet's layer, only there is no endothelium. But because it was long-standing, interestingly, the keratocytes had infiltrated into the pre-Descemet's layer, and when they go into the pre-Descemet's layer, they will produce myofibroblasts, fibroblasts, scarring. It will become very taut. Another clinically important point is when you see a strand extending from the posterior surface of the cornea to the detached Descemet's membrane, it has to be a type 1. Because I showed you those strands, they only extend between posterior cornea and the anterior surface of pre-Descemet's layer, not between pre-Descemet's layer and Descemet's membrane. So the sooner we treat the detachment, the better. Once it gets scarred, it is much more difficult, and you may need to do a descemetectomy. Here's another patient. You can see peripheral detachment, type 1. As you move towards the center, it's becoming mixed. Both are separated from each other. And as you go right in the middle, there's the type 1 component. The type 2 component has separated, but it is also torn and curled. Excuse me. So this was quite a major paper, I thought, with a lot of colleagues from India. We put together this story and published in the AJO. Now, another example where you can see that strand is extending, and that will tell you this is a type 1 detachment. So when it is stiff like that, you cannot put it back with air, as happened in this case. When we didn't know about these things, we put a lot of air to restore this type 1 detachment, but as the air was absorbing, it came right back. So you have to do a descemetectomy if there's still endothelial function, to relax, because the surface area of the posterior cornea in relation to the surface area of the detached predesmates layer, it will be much more. When this is more, that will not fit. And because it's now become a bit fibrous, it's very taut, it will try to go back unless you relax it. So that's a very important point when it comes to treating, identifying which type, how long, and then doing what is necessary. But type 2 detachment is easy to put back. Moving on to another pathology is deep corneal infections, in this case, particularly fungal infections. And this paper appeared in 2014 by Liu et al. As soon after we had published the predesmates layer. And this is their comment. We observed a phenomenon of the predesmates layer, Duer's layer, and desmus membrane split in corneas with severe fungal infection, providing pathological support for Duer's finding and adding clinical meaning to the new anatomical concept. So what they showed was that in keratitis profunda with fungal infection, you get the fungi preferentially spread along the plane of cleavage offered by the predesmates layer and the posterior stroma. And we've now got about 4 or 5 cases, and I'm sure if you go back and look at all your cases of any kind of infection, but particularly fungal infection, on OCT, you will see you get a type 1 detachment. In the center, the predesmates layer is coming off with debris, pus, or whatever accumulated in between. Very interesting that this finding can be a clue, a significant clue towards the infection being fungal. However, if you get intracorneal hypopyon, now we've all heard about, and I have also seen a few cases of intracorneal hypopyon. You see where the level of the fluid is there, and the lower part of the hypopyon is here, not at the limbus where we normally see a hypopyon. But if you do, this was a paper in case reports in ophthalmological medicine. There was a bacteria over here. They didn't have OCT. But this is a paper from Agarwal's group about a pseudohypopyon, which is an intracorneal hypopyon. And then you can see that this is a type 1 detachment. So if you make it stand on its head, you will see the hypopyon is in the lower part. This is a type 1 detachment. And that's where this pus is accumulating in the cornea because there's a cleavage plane, and it separates that plane for the pus to accumulate. It's not randomly anywhere in the stroma of the cornea. Going back to these images from way behind, before we had published the finding of the predesmates layer. So it'll be interesting to go back and look at our patients with OCT when we get intracorneal hypopyons and get fungal keratitis with the type 1 detachments to build up the evidence base to show that this is indeed the case. Now, another very, very common condition we all know of is acute corneal hydrops, right? The definition by iWiki, AAO publication, an uncommon complication of corneal ectatic disorders involves sudden onset of corneal edema due to a rupture in the desmus membrane. All of us have always been taught that's what it is the case, and I submit it's not true. You have to have a rupture in the desmus membrane and the predesmates layer, otherwise you don't get acute hydrops. And this was when the very first paper that we published, we mentioned that when we described the layer, and then we provided evidence of that in this publication in 2015, where you can see that there is this rupture. This is healed corneal hydrops, which came for a PK, so the endothelial cells have grown back on the posterior surface, but we saw there was a tear in the predesmates layer and the desmus membrane, which was scrolled in acute hydrops. If you do OCT of all your patients of acute hydrops, you will see that sometimes a mixed detachment, but you will also see a rupture in both the desmus membrane and the predesmates layer with a posterior excavation. There's a hollowing and fluid vacuoles in the stroma. This is very consistent. Now, you see this acute hydrops in a patient with pellucid degeneration, where again, you see the 2 layers have separated. The tear was more central, but you saw this strand extending, telling you that the predesmates layer is also separated. It was torn centrally. So you can get a tear in either desmus alone, in keratoconus that does not got acute hydrops. We see a tear in so many patients when you do cataract surgery, other interventions, you don't get acute hydrops. You can get a tear in both together, the pre-Descemet's layer and the Descemet's membrane, but you can't get a tear in the pre-Descemet's layer alone. It is always associated with a tear in the Descemet's membrane. Now, further proof of this came, I think fairly conclusive proof of this came by two different professors. One is Professor Murrain, and this was very early on. I think this paper was published, here, 2015. So very early on. And what he said was that when they saw acute hydrops, they put air in and marked the extremity of the tear, and they sutured the pre-Descemet's layer together with mattress sutures, leaving the torn scroll Descemet's membrane as it was. And this is comments from the paper. The fact that the pre-Descemet sutures can also be effective could be explained by the existence of the Dewey's layer. Acute corneal hydrops could be due to tear in Dewey's layer. As a consequence, pre-Descemet sutures could reattach the edges of Dewey's layer, tear, etc. A very rapid resolution. And there's also a paper, it's in a kind of a news story somewhere on the web about how the pre-Descemet's layer controls a fluid flow between the back of the cornea and the stroma. But even more conclusive evidence came from Gerrit Mellis's group. They were doing Bowman's membrane transplant in advanced keratoconus, and they often saw Descemet's membrane detachment postoperatively. None of these patients had acute hydrop. There were detachments with or without a tear. But when they were making the anterior pocket to place the Bowman's membrane transplant, if they inadvertently perforated posteriorly, i.e. tearing the pre-Descemet's layer and the Descemet's membrane, they've always got acute hydrops. They got these fluid vacuoles accumulating in the cornea. And they published this paper, Are Descemet's membrane ruptures the root cause of corneal hydrops in keratoconic eyes? They posed the question and they answered that no, what you need is as a root cause is a tear in both the layers. So our concept of pathology is completely changed now based on these findings and the existence of this layer. But the story doesn't end there, because if that was true, if you took a cornea, a normal cornea, eye-band cornea, and you made an incision about, say, 50 microns, 100 microns, so you made sure you've cut the endothelium, Descemet's membrane, and the pre-Descemet's layer, you mount this cornea on an artificial anterior chamber and you push the pressure as high as you want, you don't get hydrops. So what it tells us is that acute hydrops results from a tear in the Descemet's membrane and the pre-Descemet's layer in the context of the abnormal collagen and proteoglycan matrix of the corneal stroma that you see in keratoconus eyes. So it's more to it than just the tear, because tearing it in normal eyes will not cause acute hydrops. So interesting how we learn so much more about pathology just by understanding the underlying anatomical concepts. Now, keratoconus itself, we know what keratoconus is, or we probably don't know what keratoconus is, but there are many etiopathologcal features in keratoconus. Lots going wrong. But one of the things which I want to point out to is the following. And this was a paper published by Keith Meek's group from Cardiff in the UK. And this was again in 2015. They showed that normal corneas have a very high content of elastin in the pre-Descemet's layer, right? And they did this by serial on-phase scanning electron microscopy. It's a very tedious automated process where you make a section of the cornea, then you do scanning electron microscopy, then you do another section and do scanning electron microscopy, and it takes weeks. Then you build a stack, and by looking at the structure and giving it a color code, you can say these are elastin fibers. But interestingly, when they do that in keratoconus eyes, you can see the purple is the keratocyte, last row of keratocytes, Descemet's membrane, and the layer in between, the pre-Descemet's layer, you can see that completely gone. The pre-Descemet's layer is gone, and there is no elastin in keratoconus eyes. So saying that loss of elastin and the loss of the pre-Descemet's layer is a feature of posterior corneal pathology in keratoconus. And we know that this entity of posterior keratoconus exists. And we went on and did the same thing. When we stain the predesmate layer, you see all the predesmate layer stains green. This is for elastin. The desmate membrane only stains as a band on the anterior surface, as you see over here. The rest of the desmate membrane doesn't stain. But in keratoconus, you see the green stain is completely gone, both from the desmate membrane and the predesmate layer here. Whereas you can see that band beautifully seen in normal eyes and in the desmate membrane, and this is the predesmate layer, but it's gone in keratoconus eyes. So elastin degradation in the predesmate layers probably a feature in the pathogenesis of keratoconus, specifically posterior keratoconus. And just to again digress for a moment to say that God did not put this elastin band on the anterior surface of the desmate membrane so that we could do DMEC. It is because this tries to scroll in the direction of the arrows. We know that with the endothelial cells outside. So constantly allowing the desmate membrane to be firmly opposed to the back of the cornea so that it can carry out its function of keeping the cornea dehydrated. Otherwise, with there's no physical attachment between these two, just the interfacial matrix. Otherwise, with pressing the eye, with every heartbeat, with every breath we take, with every squeeze of the eye, we are alternating, pushing a lot of stress forces on the cornea. But this desmos can slide between that and the back quite nicely without any damage to the desmos or the endothelial cells. So I think it has a physiological role in that sense. Again, just to go on with one other condition at the back of the eye, desmetocele, all right? Now, desmetoceles, again, definition, ectasia of the desmos membrane, but not true. If you do OCT of your desmetoceles, you will find basically, again, this was in a very first paper because we had all these kind of thought processes going on as soon as we discovered the layer, that you can divide desmetoceles also into three types, not the same as the desmos detachment. Type 1, where you have the desmos membrane and the predesmos layer, which is protruding out. So the desmos membrane is covered by the predesmos layer. And I remember we were taught that the desmos membrane resists perforation, but only if the predesmos layer is there. Then the type 2, like the type 2 bubble, is desmos membrane only. But there is a third type where you have a bit of anterior stroma in addition to the predesmos layer. And this is images from Dr. Murlidhar, which he kindly shared with me. And I've used them in many talks, thanks to him, that you can see the desmetoceles are of these three different types. We're trying to get enough histological evidence to prove this. If we get desmetoceles where a PK has been done, then and look at it histologically, and even by electron transmission microscopy, we should be able to prove this concept that some desmetoceles have that. But on OCT, the evidence seems quite compelling. And then this is anecdotal. Walter Risch, who is the father of corneal dystrophies, is a world expert on that, published a paper in Case Reports in 2020 in Lewis syndrome, which is a biclonal gammopathy, and you get these paraproteinemic deposits in the corneal center, and he says a central discoid yellowish brownish discoloration in the predesmate layer. So acknowledging that that layer specifically can participate in certain kinds of pathology or preferentially has this deposits of this material over there. Now to finish off with the desmos membrane pathology, and I've already showed you this band. We know that's the band that causes the desmos membrane to scroll with the endothelial cells outside, because if you put elastase enzyme, the scroll automatically over time unscrolls, and you can see on histology the green band is completely degraded. And as you can see, this scrolling is of the desmos membrane very characteristic in pathology. It tells us that it's torn, as we see in this over here, always with the endothelial cells outside. And in DMEC, we use that as a guide to which way to unroll the scroll to do the operation. And we went on and showed this, which was published in the Indian Journal of Ophthalmology. I'm proud to say last year that if you mark the vertical and 3 to 9 and 12 to 6 positions, you will find that the desmus membrane predominantly scrolls in the 3 to 9 direction, not in the 12 to 6 direction. Now that is interesting. Why would it be? We know that it scrolls because of the elastin, but why preferentially in one direction than the other? So we said this can be put to clinical use by making vertically oval trephinations instead of circular trephinations. And if you make a vertically oval trephination and mark the horizontal axis like this, then it scrolls much less. But if you make a horizontal oval trephination, the same punch, it'll scroll a lot more. So the vertical component, if it is more, it scrolls less, as you see in these examples, than if it is horizontal. So, but why should this difference be there? Quite apart from we can use this as an adaptation of our technique for DMEC, because you make the vertically oval punch with 7 by 9 millimeters, you have a total square area of 49.5, whereas it's 50.3 with the 8 millimeter circular trephine. So you will lose a little bit of endothelial cells, but I think you will gain more endothelial cells by having very little effort to unscroll it in the eye. But this is the explanation we try to put forward, that if you take this mat, you can see you try to roll it vertically, you won't, horizontally it rules. So there must be a structural difference, but is it? What is that structural difference? So we tried to look at elastin distribution difference, and we took a cornea, we took a desmus membrane like this, we made it into a quadrant and made vertical and horizontal sections, and we found no difference in the elastin staining intensity, thickness of elastin band, or of the thickness of the desmus membrane in the vertical or the horizontal. There was absolutely no difference. But by approaching this a different way, and this is by suboptimal wavelength phonon microscopy and beryllium microscopy, we can show that when you do measure the stiffness of the cornea, of the desmus membrane, I beg your pardon, stiffness of the desmus membrane, it is much stiffer in the vertical meridian than in the horizontal meridian, which is softer. So the vertical is the green, the horizontal is the red, and you can see that the difference in stiffness is more. So if the difference in stiffness is more, it must be related to any structural proteins. And we stained for a number of structural proteins, and we found that couple of them at least are much more in the vertical section than in the horizontal section. Same protein, structural protein, more in vertical meridian than in the horizontal. So there's a lot more to learn about the micro anatomy or structure of the cornea. But is this relevant? Now, maybe, because if you look at Hab striae, when you get these tears in the desmids, they're usually horizontal, or sometimes circumferential, but usually horizontal. But if you get the same tears due to birth trauma with forceps, they're vertical. So different directional in the tears could be related to this different stiffness or differential stiffness we are seeing now with these techniques that give us a really detailed information of the very, very fine structure of the stroma of the desmus membrane. And to finish off now, we have shown that the desmus membrane stops at the periphery or merges with the layers beyond it, but the predesmus layer carries on and becomes the trabecular core of the core of the trabecular meshwork or the trabecular meshwork beams. It's a high amount of collagen and collagen 6, which is there in the collagen beams of the trabecular meshwork. It has a high amount of elastin, which is also high in the trabecular beam. So there is a structural relationship. Here's the predesmus layer from which the desmus has been removed. And on scanning EM, you can see it actually becomes the trabecular meshwork. So clearly, it has implications for glaucoma and pressure maintenance. And we're doing a lot of studies on that at the moment. And we know that it has possible effects on posterior corneal biomechanics. So to conclude, anatomy is about gross and fine structure. Understanding anatomy helps understanding pathology. Clinical manifestations of pathology are determined by anatomy. Understanding anatomy also guides surgery and makes surgery easier and safer, as we've seen with all our DALC operations. The discovery of the predestined layers has informed us about anterior and posterior corneal pathology. And with regard to posterior corneal pathology, as I've already mentioned, it has completely changed our understanding about descemet detachment, acute eye drops, spread of infections, descemetocele, intracorneal hypopyon. It provided explanation for these, and perhaps in the pathogenesis of keratoconus. More is yet to come in terms of corneal biomechanics and pressure control. I'm going to finish off by this extract from a editorial I wrote for a Brazilian journal at the time. Jose Gomez was the editor. It was titled "The Power of Observation." It's free to download. And I quoted, I don't know the author of this quote, but it's very famous and it's written in many of our textbooks as undergraduate when I read them. The eye cannot see what the mind doesn't know. And H. Lawrence added to it, what the eye cannot see and the mind doesn't know doesn't exist, at least for the person who can't see it and doesn't know of it. But then I added the following quote to it. There's a difference between looking and seeing. Only when we look at something and see beyond what the mind knows can discoveries be made. Thank you.
Thank you, Professor Dua, for that very lustrous talk. I'm sure there were a lot of learning points for all of us. I'm going to invite Dr. Basak, Professor Radhika Tandon, Professor Bhavna Sharma for comments or any questions that they might have.
May I start? Thank you, Professor.
Yes, please.
It's always very, very, lovely to listen to you speak with the great detail and the, insightful analysis of our clinical information as well as the academic knowledge, and also the ability to see things in a fresh way. A lot of things that you have covered have indicated in different ways how important it is to pay great attention to what we see and keep thinking in our clinical practice. So thank you very much. And I've definitely taken some new points from your talk today. We are very grateful to you for having shared your valuable knowledge with all of us. Thank you.
Well, thank you very much. And there are still lots of bits, as I pointed out from time to time, that need to be carried further and investigated further, like the descemetocele, providing histological proof. You have the material, you have the opportunities, you have the patients. And if you could do that, I'm happy to collaborate, or even independently, you can do that just to show that that is indeed the case. And there's so many other things that need more work.
Thank you so much.
Thank you. So if there are no comments further, then I'll invite Dr. Manu Murali Krishna for the first case. We'll start with the case presentations. Every case is going to be for 5 minutes, followed by 5 minutes of discussion. So I request everybody to stick to time when they're presenting their case so that we can have some enriching discussion after that. So first case is by Dr. Manu Murali Krishna on predescemet dots and dashes. Hand over to you.
Yes. Sorry, just a minute. Good evening, everyone. First of all, I would like to thank Professor Radhika Tandon for giving me this opportunity, and Aios as well. So I just share my slide. Is it visible?
Not yet.
Has the administrator enabled you to share screen? And is it open on your desktop?
Yes, ma'am. Is it visible now?
Not yet. So there would be an administrator who would have...
Doctor, are you on a Mac?
Yes.
You will have to give permission, I believe. Did you get a prompt saying you have to give permissions?
Yes, I given permission also.
You can again try once.
I'll try again. Okay. Now I think it's visible.
It's not visible. Yeah, now it's visible. Yes,
Now, yes.
please.
Yeah.
So good evening, everyone. I will just present my topic. It's pre-decimate dots and dashes. So no financial interest. So our patient is a 70-year-old male patient from a village of Uttar Pradesh, who is a farmer by occupation from a low socioeconomic background, who presented with complaints of diminution of vision in both eye, right more than left, for the last 10 years, which is gradual, painless, and progressive in nature. He developed chronic history. He had a chronic history of recurrent redness, watering, and foreign body sensation in early adulthood, and he's not having any associated systemic illness. So coming to the ocular examination, in the right eye, the vision is finger count at 1 meter with an IOP of 12 mm. His extraocular movements are normal. He has a few trichiatic lashes in the lower lid with severe MGT, and the upper tarsal conjunctiva showing conjunctival scarring with similar to arch line, and cornea showing multiple NMCOs with diffuse epithelial haze and spheroidal degeneration. Otherwise, his pseudophakic and a dull glow was present due to the corneal opacity. In the left eye, which is a better eye, having a vision of 6/60, and also having similar trichiatic lashes and severe MGD with arch line in the upper tarsal conjunctiva. Remaining findings are almost comparable to the right eye. Coming to the investigation, since right eye is the worst eye, and we did surgery in the right eye, I'm going to present the investigation findings in the right eye only, which is axial length is 23.46 mm in optical biometry, and keratometry was 42.05 and 44.40. Anterior chamber depth was 3.84 mm, and specular microscopy was not captured due to the corneal opacity, and USG was grossly anechoic and no optic nerve head cupping on USG. Anterior segment OCT and confocal microscopy showed some interesting finding of diffuse corneal haze with deep stromal scarring with slightly increased decimate membrane thickness and hyperreflectivity at the pre-decimatic zone in the anterior segment OCT. And confocal microscopy showed some multiple hyperreflective deposits in the stroma reaching up to the decimate membrane, and endothelial cell dropouts also seen in the confocal microscopy. And conjunctival swab was sterile, showing no active ongoing infection in the right eye. These are the clinical images and the anterior segment OCT finding. And from the history and the clinical examination, we came to the diagnosis of both eye trachomatous keratopathy sequelae with poor ocular surface and meibomian gland dysfunction, with multiple nebulomacular or corneal opacities in both eye, with right eye pseudophakia and left eye nuclear sclerosis of grade 2. So since the endothelial layer also involved and deep stromal involvement, we decided to go with the right eye optical keratoplasty rather than a lamellar procedure. So this is a post-op image showing visual acuity was 624 with pinhole improvement to 618. And graft clarity was 3+ in the day 1, which improved later, and few decimates fold. And otherwise, graft host junction was well opposed. The rest of the findings are similar. So coming to the histopathological evaluation of the host tissue, there was thickening of the corneal epithelium, and anterior corneal stroma reveals spheroidal degeneration, and significantly amyloid deposits were present throughout the stroma, and decreased endothelial cells were also documented. This is the same slide. And concurrent staining revealed apple green birefringence under the polarized light, showing amyloid deposits. And we had a similar case also having significant stromal haze and Gette and endothelial cell loss, and confocal microscopy revealed amorphous deposits all around the stroma, significantly involving the posterior stroma also. This is the clinical image. So we, based on this this case report, we evaluated detailed all retrospective analysis of all keratoplasty we did with similar trachomatous keratopathy history and secondary amyloidosis finding. And we had 15 patients with 29 and included in this study, and 31% cases in having anterior stromal involvement and 69% having posterior stromal involvement. Among these posterior stromal involvement cases, we found that circular to oval blue-white opacities in the level of deep stroma and decimate membrane. Endothelial cells were atrophic and flattened with Gette formation. Confocal revealed hyperreflective needle-shaped crystalline deposits of extracellular amyloid at various depths of corneal stroma up to the decimate membrane. These are the confocal images showing multiple oval dot and linear hyperreflective spots with endothelium showing Gette formation and dropouts. Anterior segment OCT showed hyperreflective endothelial deposits and thickened decimate membrane and deep stromal scarring. This is a histopathology slide showing amyloid throughout the stroma, extending up to the decimate membrane in the first image, and thickened decimate membrane with degenerated endothelial cells and gut formation in the endothelial side, and with apple green birefringence showing amyloid deposits in the with concurrent staining. So we described a distinct form of trachomatous keratopathy, unlike the usual presentation of dense leukomatous vascularized corneal scarring in trachoma, and amyloid deposits in decimate membrane and the corneal endothelium have not previously been reported in patients with trachoma. So coming to the current perspective, based on the new update edition 3 of IC3D classification, this revision includes an entirely new category of corneal dystrophy, that is punctiform and polychromatic pre-descemetic corneal dystrophy, that is PPPCD, with an identified gene. PPPCD is classified as type of pre-descemetic corneal dystrophy only. In PPPCD, there are hyperreflective opacities distributed at the level of decimate membrane in confocal scan and posterior hyperreflectivity in the OCT images, and which is almost similar to our case. So this is a published clinical images in the newer version of IC3D showing hyperreflective deposits at the pre-descemetic layer and hyperreflectivity in the posterior layer in anterior segment OCT. So our newer insights comparing the newer IC3D third edition update and our trachomatous keratopathy case reports. Genetic analysis was updated in newer version. No genetic analysis were available in our study report. Presentation usually after 30 years in the new pre-descemetic dystrophy, whereas median age was the 66 years in our trachomatous case series. Vision usually unaffected, and in our cases, vision is affected significantly, and we did keratoplasties. Non-progressive or mild progression in pre-descemetic corneal dystrophy, and progression was present in our case mostly because of the chronic rubbing due to rickety lashes. Hyperreflective opacities at pre-descemetic and decimate membrane, whereas hyperreflective opacity is present from the mid-stroma to the deep layers in our cases. Endothelium is not involved in the neuroversion and pre-descemetic corneal dystrophy, whereas endothelial cell loss documented in our paper. No histopathological evidence, since these cases are not visually significant and no surgeries they have done, so no histopathological evidence is available. But in our cases, histopathologically evidences are proven for a deep layer involvement with amyloidosis. So take-home message is trachomatous keratopathy can have atypical corneal involvement due to secondary amyloid deposition, unlike the usual dense leukomatous vascularized corneal scarring. Whereas trachomatous keratopathy with secondary amyloidosis can have similar features of PDCAD or might have a varied presentation of the same clinical condition. So a preoperative thorough clinical examination, ASOCT and confocals can aid in definite diagnosis and better management planning. Thank you.
Thank you, Dr. Murthy. That was a very interesting presentation of case and the articles that you presented. Professor Radhika, I would invite you to start discussion on this topic.
Yes, so the entity which has been described now is not an overlap because there's a younger presentation and there's a definite gene involved. Also, the vision is not affected. So we just want to highlight that sometimes anatomically the lesions may appear similar or on scans, but clinical medicine is not taking findings in isolation. You have to consider the complete picture. The associated detailed clinical examination and the other associated features are extremely important. As you can see that if you have trachomatous changes and you have these clinical features, you see it is a different variation of a disease process, but you should not confuse the two entities. The other thing they have also mentioned is that there is a variety which is not specifically associated with the gene, which they have said is a type 4 variant of pre-descemetic dystrophy, which is the one we feel that needs to be watched more carefully. But the one where you have an associated identified gene, that should not be mixed up. So it's very important to look at the history, look at the family members, and as far as possible, if we see these changes, it is good to do a genetic analysis so that one knows for sure which way, what is the actual pathology behind it. And listening to Dr. Dua's talk, I think we need to be a little bit more insightful and try to look further as to why does it manifest with these kind of clinical pictures. So that is something which would be very interesting. as to why it's in certain cases it is going through other stroma, certain cases it's only in the pre-descendants level. So I would feel that in the trachomatous keratopathy, it is a surface disease. There is an ocular surface problem. There is a chronic irritation and inflammation of the corneal epithelium, and that may be leading to the disease process, which is leading to scarring in the cornea and the secondary amyloid formation. Whereas in the predestined genetic dystrophy, it is not related to any ocular surface problem. So therefore, the lesion is developing just purely in the predestined layer and not affecting the vision. So that is what we feel is the cause.
I can just have one comment. I mean, is it a dystrophy or a degeneration? It's acquired. And the other comment I'd like to make, particularly for the gentleman who presented it, that an important negative finding he should mention is that this was not vascularized. Because trachoma is, like you said, a very vascularized kind of a condition. But these lesions in the depth, there was no vessels. So there were two separate things. There's vessels from the trachoma, and this per se is non-vascular. So it is a consequence rather than a direct trachoma etiology. It's a consequence of the trachomatous pathology. Like you said, two different processes happen.
So it's as far as the trachomatous keratopathy is concerned, it is not a dystrophy. It is a degeneration, and as you correctly said, it is a sequelae of the chronic process, the chronic inflammation, or the just the dry eye and the irritation by the tracheitic lashes, which probably sets a mechanism in motion. And this is not the vascularized opacity that we would normally get. So this is like a subset of cases we have seen, and as you correctly said, it's not a direct consequence of the infection, but like a down the road manifestation of the chronic ocular surface disorder.
Yeah.
So thank you, Manu. Nicely presented.
Thank you.
Thank you, Dr. Radhika Tandon also and Dr. Manu Muralikrishna. That was a wonderful case. We'll proceed to the next case then. The next case is going to be presented by Dr. Anusha Churi. Are you ready with your PPT?
Yes, ma'am, I'm ready.
Yeah, and her topic is acute hydropsin unilateral keratoconus.
Sure. Are my slides visible?
Yes.
A very good evening to one and all. I'm presenting an interesting case of acute hydrops in unilateral keratoconus under the guidance of my mentor, Dr. Christy ma'am. So, a 14-year-old girl, daughter of a pediatrician, presented to us in June 2022 with acute onset of defective vision in right eye since 4 days. There was no history suggestive of atopy or VKC, ectatic disorders in the family, previous use of spectacles, or any systemic illness. On further questioning, the mother admits noticing vigorous eye rubbing habit of the child with her knuckles during her online classes. So she had also undergone a routine eye checkup 2 years back elsewhere, and the examination was absolutely normal. Coming to the clinical examination, her right eye, the uncorrected visual acuity in her right eye was 660 with no pinhole improvement. Retinoscopy reveals a dull reflex, and anterior segment revealed, just a second. Anterior segment revealed a central 3x3 mm stromal edema with corresponding horizontal Descemet membrane tear, which is suggestive of hydrops of grade 1. And the left eye examination was essentially normal. There was no scissor reflex on retinoscopy in the left eye, and vision being 6/6. The pentagram of the right eye shows a very high keratometric values and pachymetry of 1083 microns, suggestive of the acute hydrops. Whereas the left eye was absolutely normal with K values and the pachymetric values being normal. And the refractive, there are no elevation on the posterior map, and the scan was absolutely normal. She was conservatively managed with hypertonic saline and eye ointment and responded very well to the treatment. And she was closely followed up. Her next visit was at 1 month, with the pentagram of the right eye showed a decrease in the K values. Clinically, there was some resolution of the corneal edema with apical scarring and thinning, and the pachymetry was now 538 microns. And at 3 months, we can see a descemet membrane scar, and the vision being now 618 with the acceptance of -6 cylinder. At 6 months, the vision remained same, 618 with the descemet membrane scar, and K values were roughly the same. And at 1 year follow-up, there is a change in refractive power that is noted, and the scar density reduced significantly. The K values at 1 year were 56.5 and 59.9, with pachymetry 472 microns. She was visually rehabilitated at 1 year with a RGP lens with spherical power of 5.75, improving to 6 parts. And the left eye was closely followed up in each visit to look for any ectatic changes. During the follow-ups, throughout all her follow-ups, the vision was 6/6, no scissor reflex, and the keratometric values and the pachymetric values being normal. So this eye was analyzed for the ABCD progression map, which was within normal limits, no ectatic changes seen or any progression. Similar case reports, a case report from the American Journal of Ophthalmology, which reports a 7-year-old female who was known to have eye rubbing habit, which was noticed since 6 months of her age, only in the right eye, had developed keratoconus in the right eye alone. She was followed up for 2 years, and which progressed to acute eye drops, and her genetic screening was normal. And this was attributed to her eye rubbing habit. That eye also shows in ophthalmos and severe keratoconus in the right eye. Another case report from the BMC journal, a 19-year-old male who was a habitual eye rubber developed unilateral keratoconus in the right eye, whereas the left eye was absolutely normal. Interestingly, this case was followed up for 14 years, and the left eye showed no clinical, tomographical, or biomechanical changes. And the right eye at present, when the child had first presented, was told to avoid eye rubbing, and there was no further progression noted in the right eye. And another interesting case from American Journal of Ophthalmology, this child had tachyarrhythmia. By some means, she had learned to develop, she had learned to elicit oculocardiac reflex through eye rubbing, and that alone eye had progressed to keratoconus, whereas the other eye was normal. So why is our case unique? Because this child presented with acute eye drops at presentation, who was seemingly asymptomatic prior to this episode, and it is unilateral. So I would now request my mentor to take over for the discussion.
Good evening, respected teachers. So this is Dr. Josephine Christie. Thank you, Dr. Anusha, for the neat presentation. We wanted to talk about this case because it was very unique in a sudden presentation with keratoconus, which was probably attributed to the eye rubbing that the child has developed during the COVID period, probably due to the dryness induced due to digital eye strain, or probably an undiagnosed ametropia in that eye. So what was surprising was the eye rubbing was more probably in the dominant right hand and in the right eye, which caused a quick and rapid progression to advanced KC and even acute eye drops, whereas the other eye remained almost normal. So until now, I think 1.5 years she's followed up with us and we are not seeing any changes. And since the girl was very smart, we were able to train her and also educate the parent to advise her to wear RGP contact lens after she came back from school for at least 2 hours with the other eye patching. And now, and the last visit, the child is really good, and she wants to wear RGP lens now. So that was a good improvement that we found. So what I wanted to ask to the expert panelists was, so why this case was unilateral? Is our theory right? Whether it was a due to the vigorous eye rubbing in the right eye alone due to the hand dominance? Or do you think that the other eye also requires any intervention for now? And what is the role of ocular response analyzer? And is prophylactic C3R is recommended? So I would like to hear from the panelist.
First, I would like to comment or ask, did you not do an OCT in this patient?
Unfortunately, no, sir. We didn't.
Yeah, because you mentioned desmus membrane scarring and desmus membrane tear, but I just told you that probably you would probably
it is a Duas layer also, yeah.
Also tear, but and most of these scars are not in the desmus membrane; they're in the posterior stroma, and it can be even beyond the predesmus layer that is scarred. Desmus membrane is very difficult to show. I mean, you might get the two lines because it scrolls up. Then there is no scar in between because there's no desmus membrane there. The endothelium then lines the posterior surface of the stroma, and then that's how it resolves. So when we use a term, we should try to understand whether it's really accurate or not. I think the scarring is more posterior stromal rather than desmus membrane alone. But coming to your points about the case, we've got this, age-old concept that eye rubbing, and in fact, it is the only known factor that we know associated with keratoconus, eye rubbing. Often, eye rubbing is bilateral. It's not, but you get unilateral manifestation. And I've asked this question in at least 4 or 5 different forums where we've had discussion on keratoconus, closed meetings and open meetings, and this question has come up for discussion about eye rubbing. Do we have any evidence of how many eye rubbers don't get keratoconus? See, we have all the patients keratoconus. Oh, you rub your eyes? Yes. There are people who believe that you cannot get keratoconus without eye rubbing, full stop. I mean, completely one end of the spectrum. But if you have the other side of the story, is how many eye rubbers don't get keratoconus, then you'll have a better evidence. There was probably, somebody said there was one study, but he couldn't recall which one, where there was some evidence on that, or some numbers on that. But it's kind of a study we need to do. If you ask all the children or the parents and how many of them are rubbing the eyes and then follow them up to see. So therefore, we know what exactly the role is, because there may be a huge proportion who rub, but never get keratoconus. And then why bilateral, all the features you mentioned, why she might be rubbing the eyes as the dryness or the strain or whatever, it would be affecting both eyes, but she's rubbing one. And you're right, if she's right-handed, she's more likely to rub one eye or the other. And that might be the explanation for that. But what was unusual was the very rapid progression from occurrence to eye drops.
Prof, do you think that because this was a unilateral case in the early and moderate stages, it just got missed because with the binocular vision, the child might be just normal. So instead of thinking that it's a rapid progression, could it just be like a missed theme?
I'm absolutely sure that's what I've seen many cases, even in the late teens, who've got, who have only there's no topographic evidence of keratoconus in the other eye. What topographic manifestation in one eye? And this question comes up, do we cross-link the other eye? And the answer is no. You don't cross-link you watch it very closely, because if it's normal, why do you want to treat it at that point? If you have the slightest suggestion, and the younger, the more closer you need to watch them. If she's going to rub the other eye, then chances are she will get it. But personally, I would say that if there is no evidence of any ametropia or of keratoconus anterior or posterior, then don't cross-link. Wait and watch.
Oh, great. Do any other panelists have any comment on this case?
Yes, yes. So as rightly pointed out by Professor Dua and Dr. Rashmi as well, that it could be a case of unilateral keratoconus. Other eye may be normal in that case, and we need to closely follow up the patient for any progression, any topographical changes, before taking the patient for any for C3R. So prophylactic C3R may not be recommended in such cases. Yes.
Just a small comment. We had a similar case who came in about 4 years back with eye drops in one eye and the other eye, showing no topographic evidence of keratoconus. But as we followed her, we found that the other eye developed changes. And then we did the C3, we did the corneal cross-linking. So, and the changes happened, she was following up regularly every 3 months for the last 4 years. Then last year we saw that she did have changes in the other eye, and then we went ahead and did the cross-linking. So yeah, it's important to follow them up regularly. Thanks.
Yeah. Yeah. Thank you. So
Can I ask a
moving on.
question?
Yeah, sorry.
So if you have only elevated posterior float, but nothing in the front, right? And you form first or a very early keratoconus, and your cross-linking is only stiffening up the front, would you still rationalize, or would in theory, can the stiffening of the front arrest the progression of the back? Because your cross-linking doesn't go so far back.
Yes,
I mean, the thought. I
yes,
mean,
I
people
agree.
will say, do it.
Yes, yes. There's nothing else we can offer, so we do it.
Yes.
But I agree with you on that side.
But the question is, like, this is again one of my quotes. I've used it. Is it something to do rather than something that does?
Yes. Yes.
The first part is what you to give you comfort. You've done something.
Yes, yes, yeah.
But does do something for the patient.
Yeah, I agree with you.
Yeah.
Totally agree with you. Yeah.
I think one other point important in this is that you have to control any eye allergy or eye rubbing. Underlying disease has to be treated, because that's what causing the eye rubbing. And keratoconus, being an asymmetric disease, is showing up in one eye, maybe in the other eye in due course of time. If the underlying pathology progresses, you may see changes. So we need to watch out and follow up the patient. But I would definitely treat the patient with lubricants and maybe any anti-allergic treatment. If he has evidence of the same, I would treat that.
Yeah, she mentioned in the beginning there is no allergic eye disease.
Yeah.
Or, they mentioned in the beginning, but still, I think the point is well made that if there's any underlying factor, even the eye rubbing, if she can stop it, one has to treat that to prevent progression.
Yeah. So it is like there is some underlying pathology, but because she's rubbing the right eye more, it got manifested in that eye first, and then it is possible that she will have in the other eye as well. So I think that is. So we moving on to the next case in the interest of time. I'll invite Dr. Jayashree P. For her case on bilateral recurrent corneal perforation in a case of bullous SLE.
Good evening, everyone. I thank Dr. Geeta ma'am and Aios for giving me this opportunity. So this is a 26-year-old female who was bullous SLE positive, was referred to us with pain and redness in both eyes for 5 days. She was having this tense bullae in her trunk, abdomen. She had oral mucosal involvement and genital involvement. On examination, her vision was 6/9 in the right eye and 6/6 in the left eye with mild conjunctival congestion and SPKs. So we prescribed her hourly lubricants and antibiotic steroids 4 times a day. At this point, she was already started on oral prednisolone and dapsone. So over 2 days, it rapidly worsened to severe central corneal thinning with the descemetocele in the right eye and perforation in the left eye. Swab cultures and viral PCR were sent, and it were all reported negative over the week. Right eye was managed with a multi-layered amniotic membrane transplantation, and left eye was managed with glued BCL, and the AC was well formed. She was put on intense topical lubricants, hourly antibiotic steroid combination, cycloplegics. And as per dermatology and immunology advice, she was also started on prophylaxis of acyclovir, but it was stopped after a week. And a week later, she develops an epithelial defect like this under the AMT, but it slowly healed over a period of 4 weeks, and the AMT integrated well, and the sutures were removed after that. However, the left eye, after 4 repeated attempts of glued BCL, she had to undergo a tectonic keratoplasty with an immediate post-op vision of 3/60, which subsequently improved to 6/18, and she was discharged at this state. Right eye was doing all good. And a week later, she comes back for follow-up with this presentation in the right eye, with the central corneal infiltrate, total epithelial defect with surrounding thinning, and a peripheral ring-shaped corneal infiltrate. Scraping was sent, which grew Burkholderia sinocepaceae, and it was sensitive to ceftazidime. She was started on 45 drops hourly, and steroids were promptly stopped. And her systemic condition also worsened at this point. She developed high-grade fever, which was co-managed with medicine and immunology. And her right eye infection worsened and perforated, requiring a tectonic keratoplasty. At this point, left eye was doing well with a BCVA of 618. Unfortunately, 4 days post-op, she sustains an open globe injury to the right eye due to domestic abuse, leading to graft dehiscence and lens extrusion. She underwent emergency anterior vitrectomy and graft resuturing for this. And in the same week, she developed neuropsychiatric manifestations of SLE, which was managed along with psychiatry team with antipsychotics, and her immunosuppressants were hyped. And the right eye graft had a non-healing epithelial defect, and over 6 weeks, it developed severe thinning and the graft melted inferiorly, requiring a repeat keratoplasty. At this point, this was 3.5 months from initial presentation. She undergoes a second keratoplasty in the right eye, which had a persistent epithelial defect, which was slowly healing. She was put on 4 times antibiotic steroid drops and lubricants half hourly. While the left eye, after 3.5 months of being good, developed a small epithelial defect at the 7 o'clock graft host junction. And there was a loose suture. We don't have a picture of that. And it developed a suture infiltrate at that site. And after suture revision, this defect was healing and the infiltrate also reduced. 4.5 months post-op, left eye develops a decimetocele in that area, 2 mm with clear margins, and it was managed with a glued BCL. And 6 weeks, it stayed like that, and we noticed some signs of infection here, and we sent swab for cultures, which grew Achromobacter xylus oxidans, which was sensitive to ceftazidime, and she was given ceftazidime hourly and lubricants half hourly, but the thinning worsened under that and had spontaneous perforation. And 6 months from the initial presentation, she undergoes a tectonic keratoplasty in the left eye. Intra-op, she had spontaneous lens extrusion and IOL was implanted. That host culture also grew the same organism, so she was continued on ceftazidime hourly, and steroids were kept low at 4 times a day and lubricants half hourly. So now we are standing at this point with the right eye graft melting with a non-healing epithelial defect, which is planned for a repeat keratoplasty tomorrow. And the left eye inflammation is reducing and the graft is healing. And now she has also developed lupus nephritis, for which she underwent a renal biopsy, and she was given a dose of IV cyclophosphamide. Now this is her current immunosuppressants. So these were the management challenges that we've been facing: the extremely aggressive course of the disease and the high immunosuppression state. So the initial manifestation itself was a bullous SLE, and it led to multiple organ involvement within a span of 6 months. And the highly immunosuppressed state also made her susceptible to a lot of infections. And 40% of disease mortality in SLE is reported secondary to infections. And at least in the initial part of the disease stage, we are not sure about the compliance because of her lower socioeconomic status and the domestic abuse. Some of it was mitigated by help sought from the social welfare services. And further prognosis in this case is a big query. So there is very few reports of bullous SLE being the initial manifestation of SLE. It's very rare, and mucus involvement is seen in 50% and lupus nephritis in 50% of the cases. When the patient develops nephritis, that suggests a very poor prognostic indicator of the disease activity. And we couldn't find any reports of ocular manifestations in bullous SLE as such. It's basically a dermatological diagnosis, and we all know the ocular manifestations of SLE, but corneal perforation, severe melting is extremely rare. So bullous SLE can present with sight-threatening ocular surface disease, which can be a management challenge even with a multidisciplinary approach. And to our knowledge, this is the first well-documented case of bullous SLE with such severe ocular surface manifestations. So this was the team managing the case. Any further suggestions on further management are most welcome.
So this was a case of all the king's horses and all the king's men unable to control the problem here. And it's been very harrowing for us as a team managing her for the last 6 months, and for her family as well, because they have been in and out of hospital admissions very frequently for multiple surgeries, multiple diagnostic what tests, and immunology consultation, internal medicine consultation, managing so many problems. So we definitely really would like any comments or inputs from experts here, Is there something, is there anything we're missing? Is there anything more we could do for this patient besides just repeating, just going on with the flow, And we are also very apprehensive about the prognosis for this particular patient.
I'm not sure it's just a wild card. Insulin drops nowadays, people are using that for non-healing defects and stuff like that. Although it's not proven, they're using it more for neurotrophic kind of defects. This is much more than that. But the mainstay of treatment is systemic immunosuppression. I think when you mentioned she's cyclophosphamide, I might have missed it, whether it was intravenous or whether it was
Yes,
oral.
intravenous, because this lupus nephritis 4+ proteinuria. So the immunologist decided to start on cyclophosphamide.
That's a pretty heavy gun. And if
Yes.
you're giving intravenous, then that would probably help control once you control the inflammation, then you have a better chance of your ocular intervention succeeding. Otherwise, the whole disease just manifests in the eye and everything goes. It is a huge challenge. This one is not easy.
Maybe I would have thought about doing tarsorrhaphy when I did the repeat PKP.
Right.
Maybe it may have some protective effect in terms of, maybe from the injury and even the surface. I think the tear film, everything would keep it. So you might have a lesser chance of breakdown, at least from any tear film related issues.
Right. So we'll do it the next surgery we do it with. He has a PD, we'll do that then.
But she had the bullous, when you say bullous changes, they would be affecting her conjunctiva as well all over.
Yes, this bullous SLE, when we looked at literature, as it does, there is really nothing indicating conjunctival disease here. But yes, we have encountered 2 other cases in the last 5 years, again referred to us from dermatology, patients who were admitted with them, and one of them had a very bad prognosis. Both her eyes were involved, and she developed multiple organ failure and succumbed within a very short span before we could do anything. So we are wondering, are we seeing a very severe extreme variant who needs very immunosuppression, as you said, heavy doses of immunosuppression right at the outset. And without when we see eye involvement with bullous SLE, we might as well go in and treat it very aggressively at the outset to prevent such a prolonged protracted course. Might save vision.
Sure, I think what we have to convince your immunology colleagues is that eye involvement is more serious than nephritis, because if they go blind, there's there at least you have something you can do, dialysis or whatever. So it should be taken at equal, if not a bigger, serious footing, and therefore indication for treatment should be, like you rightly say, much early on.
Yes, it took us a while to convince them. Yes, they were not very. It took us a while to push them to.
It is an eternal problem, even for us, and that's a dialogue you have to have. See, our rheumatologist colleagues do not want to treat a patient if the joints are not affected.
Absolutely.
So that's not the point. The eye is affected, same disease, and then they eventually get convinced that this is important, but in the beginning there's a lot of resistance if the joints are not involved.
So we'll really keep pushing.
Yeah.
Thank you.
So before we move on to the next case, I'm just going to take a few questions that have come up on YouTube where people are also watching. So Dr. Charul Jain is asking, good evening, sir. There is a very recent article where they have published acute hydrops without a tear in Descemet's membrane plus Dua's layer. How is that possible?
I like to read the article. I haven't read it, but there has to be a tear for the fluid to get in acutely. It must be very rarely a peripheral tear. Usually it's a pretty obvious tear, and without any tear in the back of the cornea, unless it is gross edema from some other cause, and then therefore not acute hydrops.
Yeah.
Because if you get edema in keratoconus, I think Beener's got a case where we had exactly the same argument. It was PUK with edema that looked like acute hydrops. Therefore, we said this keratoconus are very subtle in the other eye. But we were saying that edema from any cause can cause, because of the altered proteaminoglycans and the ability of the cornea to swell so much, whatever is causing that edema might cause it to swell a lot more and give it appearance of acute hydrops, rather than it being due to the mechanism that we understand.
Right. There is one more question from Dr. Nikhil Gokhale. Is there any observation on predesmetic layer in Fuchs dystrophy? We know that descent membrane thickness increases as the endothelial cells deteriorate.
We have done confocal microscopy examination of normal and abnormal situation of the predesmate layer. I think that's an abstract we're presenting with my Italian colleagues at the 6O meeting, which is next week, of what is happening at the back of the cornea. And there are changes in the predesmate layer that you can see, but understanding confocal microscopy of the normal predesmate layer took a while, and then to show that this is abnormal. But I think it will emerge in the fullness of time, that there are changes happening over there. I think, like I said, there's some evidence we're presenting at this meeting.
Okay, great. And one last question from Dr. Neeraj Sood. Which C3R technique works best for Professor Dua?
Which we do our standard technique. You know, we have a 10-minute soak and a 12-minute exposure with the Evedro machine. That's what we do. It works reasonably. We've had only one case of infection in a child, so that's why I was saying it's not a treatment without risk. You can have serious problems if they get infection, but so that's what we do. You know, we have a 9mm. We always do epi off. We never do epi on, and so that works. I mean, I haven't tried different techniques. In the beginning, we had a few cases where we tried the really accelerated method of 4 minutes, where you have 1 second on, 1 second off, pulsed, and doing the whole CXL dose in 4 minutes. And that we had 7 cases of haze, stromal haze. So we quickly abandoned that technique. And that was in the first year when we started quite a few years ago. And since then we have not changed it.
Okay, great. So now that we've answered the YouTube questions, we'll go to Beena's case if she's ready. Beena? Yeah. So Beena will be presenting on surgical management of peripheral ulcerative keratitis. Over to you, Beena.
Can you see my presentation?
Not yet.
1 minute. Now?
Yeah, now we can. Please go ahead.
Just a minute. Okay, good afternoon, everyone. I'm Dr. Kulkarni, and I would like to begin my presentation by thanking Dr. Said and Prof. Dua to give me the opportunity. So there is no financial interest or relationship to disclose in this case presentation. I'm going to discuss a case of a 47-year-old male who first presented to eye casualty with a sudden onset of left eye blurred vision, grittiness and watering over last few hours. He had come into eye casualty in 2022. On ocular history, he had a left eye weak vision which was long standing, and the cause was not known. The past medical history, he has atopic eczema with asthma and multiple allergies to animal fur, dust mite, etc. Drug history is a regular user of inhalers and steroid skin cream. So on ocular examination, both vision of right eye is 0.0, left eye was counting finger at presentation. IOP of the right eye was 9 millimeters mercury and left eye 2 millimeters mercury with eye care. Slit lamp examination showed the following presentation. The left eye the cornea was edematous locally, especially inferonasal, and you can see here a plug of iris tissue was blocking the corneal perforation with picking of the pupil. The AC was very flat, and initially the clinical diagnosis of acute eye drops was made with perforation, and perforation was attributed to the chronic application of the steroid cream over the face and the eyelids. After the diagnosis, he had a left eye emergency corneal gluing, but the corneal glue came off the second day, and for which it was repeated again. Sorry. So this is the OCT image of the cornea, and you can see the localized corneal edema with the corneal elevation. There is a lot of intrastromal corneal haze and cyst formation. For the suspected diagnosis, the pentacam of the other eye was done, which showed a localized hotspot in the right eye. And localized pachymetry reading was 431 microns. So right eye showed very early keratoconus changes. Then after the second gluing, the glue again came off. As you can see here, the cyanoacrylate disc had migrated away from the perforation site, and iris tissue was again plugging the perforation. So he had a repeat glue for a third time. And when the patient came back in 1 week's time, it appeared that his inflammation in the left eye had got worse. You can see the corneal thinning has got aggravated with a bullous appearance, and this localized corneal thinning is overhanging the limbus. There is localized scleritis like picture, and on fluorescein staining, you can see a localized small sidal positive sign. So this picture was very confirmatory for PUK diagnosis. Based on this diagnosis, plan was made or decision was made to undertake a lamellar sclerocorneal grafting, that is the banana graft. So I'm going to show the video to demonstrate this technique. So first of all, this surgeon has done a localized conjunctival peritomy and debrided the corneal epithelium. So once the corneal epithelium was debrided, the corneoscleral graft was processed with diamond blade at 200 micron depth of incision was made in the cornea. which was fixed onto the artificial antechamber, and the lamellar, the corneal scleral tissue was dissected with the 200 depth microns, limbus to limbus. Then the affected area was marked over the eye, and it was then traced over the transparent plastic sheet, which was then marked on the graft. The graft was now cut, and the scleral part of the graft was dissected to achieve the 200 microns thickness. It was then glued onto the affected corneoscleral part with fibrin glue. The graft was then stitched at the scleral edge and the corneal edge with the 10 interrupted nylon sutures. Then the conjunctiva was adhered back with the fibrin glue. This is the end picture of the procedure. So following this technique, we had sent the samples of corneal epithelium and conjunctival tissue for histopathology. And the report demonstrated that presence of hemosiderin deposits within the macrophages around the small vessels. That is called as a pulse stain. And there were numerous CD68 positive histiocytes, which suggested small vessel vasculitis. So blood test for autoimmune screen and infectious diseases such as herpes, HIV, syphilis, TB were all negative. And patient had some eosinophilia, which demonstrated his atopic tendency. So 1 month post-op, patient presented with the signs of graft rejection. The graft site was edematous. There were few loose sutures, and again there was inflammation and redness in the left eye, for which the patient was treated intensively with steroid drops, and the oral steroids were increased, but satisfactory resolution of rejection was not achieved with this treatment. Then he was referred to rheumatology for consideration of immunosuppression. And they started him on 15 milligram of methotrexate with folates weekly, and oral steroids was gradually tapered. After this treatment, he responded very well. His condition stabilized, and after 1 year of post-op, he's got a good vision with a 0.3 logmar, and the eye is quiet. He didn't have relapses. Recently, he was reviewed for 3 years post-op follow-up. Again, there was no relapse till now, and he has a good outcome. So this is the OCT image from the pre-operative. You can see the cornea is quite edematous with stromal edema. It is not very clear picture, but possibly there is some descemet tear here, which initiated the diagnosis of acute hydrops initially. And this is a 6 weeks post-op image where you can see the graft is integrated very well with the underlying corneoscleral bed, and there is a regrowth of the corneal epithelium. This is a OCT scan done at 1 year, and you can see the remodeling of the graft has happened. The graft edema has resolved, and it's quite merged with the original corneal scleral tissue. So incidence of the PUK in UK is estimated to be 0.2 to 3 per million population. Females are more affected than males, except for the Moran's ulcer cases. Most of these PUK cases are formed by the group of inflammatory conditions, such as the rheumatoid arthritis, SLE, and granulomatous polyangiitis. Then they form at least 53% of the cases. So PUK is a unilateral crescent-shaped stromal inflammation which involves the juxtalimbal cornea. and leading to the sectoral thinning of the affected area with and without episcleritis or scleritis. So, as I said, the collagen vascular disorders constitute 53% of the cases, and rheumatoid arthritis has been associated with increased incidence of perforation in patients with keratoconus. But however, this patient had only dermatological history of eczema and asthma, which suggested his atopic tendency, but we failed to demonstrate any autoimmune condition in this patient. So, PUK is also an ophthalmic emergency with increased risk of corneal perforation and blindness if not treated expertly. Management requires multidisciplinary collaboration with long-term immunosuppression treatments and close follow-up for relapses. Good patient communication and education regarding treatment compliance is crucial for treatment success. So if perforation is less than 3 millimeters, cyanoacrylate gluing with BCL should be attempted, and conjunctival resection adjacent to the lesion helps to heal as it blocks the inflammatory mediators. Lamellar patch grafts like banana grafts are more effective than the full thickness PK or tectonic grafts because they reduce the risk of rejections. The graft leaks possibility is reduced, and there is no loss of globe integrity if the disease progresses. So patient presenting with advanced PUK associated with corneal perforation, increased inflammation such as scleritis and connective tissue disorders have poor visual prognosis, with 65% patients having counting finger even in spite of the treatment. And unilateral corneal perforations have approximately 24% mortality risk within 1 year, which increases to 50% in bilateral corneal perforations. So due to the increased possibility of having severe PUK in keratoconus patients with associated connective tissue disorders, awareness should be raised to effectively treat these conditions intensively in keratoconus patients for better visual outcome. I would like to have further opinion from the panel whether how to treat these conditions differently, or is this the effective way to treat? Thank you.
Thank you, Dr. Pina. I think we'll start with Prof. Dua for the initial comments, and then we can go to the rest of the panel if they had anything to add.
Yeah.
So just the question that was asked by somebody from the audience, can you get acute eye drops without tear? Now, in this case, they had a perforation, obviously, so there was a tear. But you see, this patient, I don't think had acute eye drops. It had all the features of acute eye drops due to the PUK and the inflammation. The patient had small vessel disease. So small vessel disease, there's an immune process going on, peripheral ulcerative keratitis. When they get corneal edema, they can be much more severe in a keratoconus patient. Now, you want to call that acute eye drops or not, and if the patient, say, didn't have perforation, probably the edema would still be the same. Maybe there was same edema before the perforation occurred because they manifested with the perforation. And when you do get a tear, even if there was in this case, which we were not sure of, it won't be that far peripheral as was suspected in this case. All of them are not classically associated with acute eye drops in keratoconus, but you can get an acute eye drops like picture because of the edema and the distribution of the fluid that occurs because of the abnormal matrix. That clearly correlates with that question.
Thank you, Prof, for that understanding. Any other comments from any other panelists or questions before we move on to the next case? Okay, so our next case will be presented by Dr. Isha Chaudhary. I hope she's ready. The case is Tina's patch graft, nature's glue.
Good evening.
Dr. Isha?
Dr. Bina will have to stop sharing before I can share. It's just telling me that I cannot share while the other participant is sharing.
Yeah.
Maybe not.
Now I think you should be able to.
Yes. Can you see my screen?
Yes, doctor is visible. You can start.
Okay, thank you. Good evening, everyone. I'm Dr. Isha Chaudhary from Dr. Shroff's Charity Eye Hospital, and today, through 3 short cases, I'm going to describe how a Tennant's patch graft can be a more natural and a more anatomical replacement to glue, that is, the nature's glue. So the first case is of a 45-year-old male, known case of peripheral ulcerative keratitis. In 2021, the patient had presented to us after getting a cyanoacrylate tissue adhesive with BCL in his right eye for peripheral thinning elsewhere, and had eventually healed. 2 years later, he presented to us with redness in the left eye since 15 days. On examination, congestion was present. There was a superior corneal thinning from 10 o'clock to 12 o'clock with epithelial defect, which was suggestive of an active disease. And over a course of few days, in the view of progressive thinning, a conjunctival resection with cyanoacrylate glue application was planned. So on the day of the surgery, we performed it under a peribulbar block, gave brimonidine eye drops, constrict the blood vessels, did a conjunctival resection as usual. But instead of placing a tissue adhesive, we harvested a Tennant's graft from the infratemporal quadrant. And placed it in the area of the defect with the help of fibrin glue. Over it, we also placed an amniotic membrane graft. And then a BCL. So in the first week post-surgery, we can see that the tissue is well opposed. The AMG also can be seen over it, and it seems to be well integrated. And 1 month post-surgery on the ASOCT images, we can see the Tennant's patch as a hyper-reflective structure, which is compact and well integrated with some volume replacement as well. So the second case is of a 60-year-old lady, known case of rheumatoid arthritis, who was already on treatment. There was a history of TABCL done elsewhere in the left eye. So when she presented to us, the visual acuity in the right eye was 618 parts, and in the left eye it was finger counting close to face. If we see here, both the corneas were dry. There was a severe dry eye. Right eye was pseudophakic and left eye had a cataract. And we can see here the presence of TA and a flat AC. So like we usually used to do, we repeated a TABCL with AC reformation and also performed a bilateral punctal cautery. But unfortunately, by the 10th day, the anterior chamber flattened again. So we again performed, which was the third TABCL for the patient, and eventually the anterior chamber flattened again. So for the fourth time, we decided not to plan a TABCL and to plan a Tennant's patch graft instead. And if we see here, so on the first post-operative day, the graft is present, it's well integrated, and the AC is well formed. 2 weeks also, the AC is well formed and the eye is the eye is more quiet. And at 3rd week post-operatively, we've removed all sutures and the tissue is well placed. So the third case is of a 36-year-old male who was a known case of graft versus host disease. He presented to us with the right eye graft melt and the left eye central tissue adhesive for a perforation from elsewhere. So we performed a right eye keratoprosthesis with AMG in his right eye for early visual rehabilitation. For 14 months, the patient maintained a very good visual acuity of 618, And after 14 months, for the first time, we noticed approximately 3 to 4 mm pericylindrical melt in this area. Considering that it was a sterile melt, a Tenon's patch graft was performed in the pericylindrical area. If you see here, this is the area of the melt, and we performed a Tenon's patch graft, and on the ASOCT image post-operatively, we can see this Tenon's patch graft, which is well integrated again, and is also epithelialized. So Tenon's capsule is an elastic and vascular fibrous connective tissue that surrounds the globe up to the cornea. The good thing is that it has good tensile strength and pliability and can be molded into it can be molded into the way we want and apply it in the area and just the shape we want it to. Also, availability is not an issue, so it's a valuable patch graft resource for small corneal perforations. It's also postulated to produce autologous fibroblasts and connective tissue, which allows it to be incorporated into the healing corneal tissue. So the advantages of it being autologous make it readily available. There's a lack of immune response, there's fibroblastic activity, and also there's minimal post-operative vascularization as opposed to a cyanoacrylate glue. Also, if you're not using the fibrin glue and we're using sutures instead, the cost is less. And also, we're not dependent on an eye bank for it. So the potential disadvantages are that maybe in some cases, passing interrupted sutures may be cumbersome or tedious or may not be possible. Also, if we do it in the central part, which is the visual part, then maybe it hampers the vision. Also, using fibrin glue is easier, but if the suturing is done properly, maybe we can do without it. So in a nutshell, it's ideal in cases of desmetocele or smaller perforations. Also, it is a better alternative in cases of SJS and OCP as compared to a tissue adhesive, where maybe putting a contact lens is not possible, and being a soft structure does not cause a lot of foreign body sensation, even if there is no BCL. And of course, when cyanoacrylate glue is not available. Thank you.
Thank you, Dr. Isha. I'll invite Dr. Manisha Acharya to lead the discussion on this, please. Ma'am, you're muted.
Very good evening, and thank you for the opportunity. Dr. Isha, very well presented. And I think what we got from here and what we understand from the Tenons is that it is like anatomically, when we're talking about anatomy, it anatomically just integrates with the cornea in most of the situations where there is a small perforation, and we feel that tissue adhesive may not be able to seal that big an area. Also, when there is an immunological problem in the eye, maybe in the form of OCP, maybe when when it's sort of gutters forming away, it definitely is the patient is much more comfortable after this as compared to the tissue adhesive. I would like Dr. Dua's opinion regarding this, and what has been his experience, if any, and how does he feel about the nature's glue rather than we give the glue ourselves?
Thank you very much. I think they were excellent cases, and it's a very good means of dealing with these situations. It is nature's glue, but in your cases, you use fibrin glue as well to attach it. So fibrin glue is more expensive than cyanoacrylate glue and is less likely to be readily available than cyanoacrylate glue. But I suspect you would have just as good results if you just stitched it into place with mattress sutures or some tacking sutures rather than having to glue it. Glue, of course, fibrin glue does help quite a bit. The amniotic membrane placement, again, when you put the Tenons, what was the rationale of that? I suspect you wanted the epithelial cells to grow quicker on the amnion than they would do on the Tenons, but it should then make sure that the amnion edge is underneath the conjunctiva edge rather than on it. Otherwise, cells can't grow on the amnion. So that probably a small technical detail which wasn't quite visible in the video, but I think the use, and you showed very effectively, it's very, very effective, and it's very promising, very easily available tissue. With OCP, where the inflammation is there all over the eye, and so if you're taking conjunctival or subconjunctival tissue, you may find you're taking inflamed tissue. That might be a thought in cases of where there's active inflammation going on. It should probably not make a difference, but it's just a thought. But there is one paper I'm reminded of from one of my colleagues in Leicester, very close by, where they took a scleral patch graft. So they went down, took a small bit of sclera and used it to treat a paracentral perforation. And the interesting thing about that was after a year or two, that had completely cleared and become transparent. So if you watch your tissue over time, what happens is that the keratocytes migrate into it. And if the keratocytes, when they migrate and repopulate as a response to wound healing, they change to fibroblasts, myofibroblasts, but eventually they do revert back to their keratocyte original CD34 positive morphology, and they may lay down regular collagen then and make that scaffold transparent in which they're growing. Because this was very, very interesting to see how the scleral tissue, very, very opaque, much opaque, more opaque than what you showed with your tenons, that became clear. So over time, it'll be good to watch your tenons graft and see how they clear.
Okay, thank you.
Yes, and then one quick comment here that the tenons patch graft, the one more advantage which we see across is like inflamed surfaces, very ocular surface, bad ocular surface. It buys you time for keratoplasty, for any corneal transplantation. By the time the ocular surface restoration is there. So like previous cases like SLE and PU case, maybe for a small defect, you can cover it with tenons and later on do with PK or any lamellar procedure once the ocular surface is controlled. So would prevent any rejections and prevent any further perforations or melts of that graft.
Thank you.
Manisha ma'am, I have a small doubt. So in the first case where you used the tenons graft, so it was a PUK case where we did a conjunctival resection. So when we put a tenons graft, it obviously incites some vascularization. How do we justify that, ma'am? Is it really necessary to put a tenons in that place?
Alternative way of treating it, and actually these cases were managed by Dr. Sangwan was one of those when we were discussing that this could be one of the modalities. Let's see how they integrate well in these immunological conditions, and that was the reason I think Isha was there, and she was like, it was more like that how an ASOCT. And we are able to demonstrate that how well it is going. This was one of the early cases where we did that. So that was more.
Thank you, ma'am.
But I think gluing that with that resection would have also perfectly worked well. So it's not that that's the only one.
Thank you.
Great. Thank you for the great discussion. We'll move on to the next case by Dr. Denise on triple anterior chamber. Dr. Denise, Dr. Fogler.
I think she had forwarded the pre-recorded presentation. Does the team have it?
She says it is pre-recorded. Dr. Fogler has the video. I'm not sure if it was shared with the admins.
No, I had sent it to Dr. Santosh. Let me see if I have it on my phone. I'll play it.
Sure.
Tijuana, Mexico, and it's a pleasure to present this case with you. This is a 54 years old healthy male. He has a corneal scar in his right eye due to infectious keratitis in 2021. He
Is it visible?
wears scleral contact lens in his right eye,
It is
but is
visible,
not happy with corrected visual
but
acuity
the
and quality of vision.
speaker window is
His
covering.
left
Yeah,
eye is
this is
with
better.
poor vision due to macular scar, ptosis, and exotropia, secondary to a trauma.
I'm sorry. Yeah. I'm just trying to see if I can.
At examination, we can see that he has a corneal
Dr. Rajesh, any chance we can switch
scar,
the device?
which is affecting his visual axis. In the OCT, we can see a depth of 339
I think it
microns.
was mailed to you. I'm because I'm trying it on my phone and it's not.
I'll just you can send me again. It was not mail. I don't have it. You can just send it to me. I'll play it from my side if possible.
Okay,
Sir.
I'll just forward the
I'm
email.
just dropping you the email ID.
Sure, I'm just sending it across.
Dr. Rajesh, I put it in chat also. I put sent you on WhatsApp also.
Great. Until then, until we see Dr. Fogla's video, maybe I'll just ask Prof. Very interestingly, you were mentioning that collagen cross-linking actually just strengthens the anterior part of the stroma, anterior two-thirds of the stroma, doesn't really affect the posterior cornea, where we are thinking the actual pathology might be. What do you think causes the arrest in the progression, which in the long term is like all sometimes it also causes flattening? Do you think it is only because of the scarring process and the cross-linking process that the posterior pathology also halts? Or Prof, I think you're on mute.
Thank you. I think, like they say, if you give me the facts, I'll find an explanation. But the fact is that it does halt progression. What we need to selectively look at is there are two things about cross-linking. One is that when you've cross-linked in the patients who've got a clear posterior elevation, does the posterior elevation extend more while the anterior topography remains unchanged? But clearly, as the cornea thins, if you stop it thinning and you strengthen the front, the back, the buckling effect won't come. So even though it is starting at the back, by stiffening the front, you prevent the front from protruding more, and hence you prevent progression. But whatever the pathology at the back might still be progressing. That's one. The second point, and we can talk about that more, but is that we only cross-link about, say, 9 millimeters, give or take. The periphery is not cross-linked. And what happens to the periphery over time? We followed it up for 2 years and we published this result that the peripheral thinning does not progress after cross-linking. The peripheral cornea doesn't thin. But if you look after 10, 14 years, and when you've done corneal grafts for patients with keratoconus, in the past we did a lot of PKs, what you'll see is that when they are late in the 60s, the periphery is extremely thin. and the whole periphery of the cornea becomes thin. So that process carries on in the periphery, which we are not cross-linking. Therefore, what you're not cross-linking continues to progress. Therefore, if you're not cross-linking the deeper layers, either going to continue to progress. I mean, these are questions that are not yet resolved. It'll come out over time, but we know for sure that I've seen so many of these cases, patients in the 60s who had penetrating grafts, even dark now who are old, the periphery continues to thin.
Okay, yeah.
And that's where a crosslink doesn't reach.
Yes. Another question on a different topic altogether would be that we saw you showed the types of Descemet's membrane detachment, the study that got published in AJO. So when we actually have a DM tear and the DM scroll that we see on OCT, that would by default go in type 2
No.
DM detachment?
So if you see a tear with a scroll, but
Yeah.
remember, that would go in a type 2 if you see a scroll. But it might be a mixed, where the type 1 component is there, but only the type 2 is torn. The type 2 component then you will see the scroll. So you can see that on OCT. When both are torn, like in acute hydrops, you tend not to see a scroll if it is attached to each other. As we see in PDEC tissue, it scrolls but very little compared to DM alone. So all the scrolling is a feature of the Descemet's membrane. So if you make PDEC tissue where the two are attached, effectively like a type 1 separation, the scrolling is much less. So, and the PDL on its own doesn't scroll. It's only when attached to DM it scrolls a bit. So with that in mind, you can then make your interpretation of what that scroll means.
Correct.
So like you said, effectively a type 2, maybe a mix with the type 2 component torn.
Yeah, so if we are seeing the cord also and the scroll as well, then it might be the mixed type. Yeah. Okay, got it. Do we have the video?
Yes, should I play, Doctor?
Yes, please.
Thank you.
Hello, this is Dr. Pincus. I am from Tijuana, Mexico, and it's a pleasure to present this case with you. This is a 54 years old healthy male. He has a corneal scar in his right eye due to infectious keratitis in 2021. He wears scleral contact lens in his right eye, but is not happy with corrected visual acuity and quality of vision. His left eye is with poor vision due to macular scar, ptosis, and exotropia, secondary to a trauma. At examination, we can see that he has a corneal scar, which is affecting his visual axis. In the OCT, we can see a depth of 339 microns. I decided to make a doc, and here we have a video of the surgery. There's a trepanation, then debulking of the anterior stroma, then a first attempt of big bubble. It's done and failed. So a second attempt is made and also failed. So I tried again with a third attempt, trying to be more deep this time, and also with no success. So then I decided to use viscoelastic, and here we see that a viscobubble, it's forming a type 1 viscobubble, then it explodes, and I continue with the surgery. I made a paracentesis, then the stabbing, and removed the stroma with difficulty because I wasn't deep enough. And when I remove the stroma, I can see that there's a rupture in predecimate's layer or duas layer, and bare decimate, it's visible at the center. So then I proceed with the preparation of the donor cornea, removing the decimate, then suture the donor cornea and finish the surgery. On postoperative day 1, patient was 20/60 with clear vision, and he was very happy. At the slit lamp, I could see that decimate is not attached, and also duas layer is not 100% attached. So we have double or triple anterior chamber. We can see here in the OCT that decimate's membrane is totally detached, and duas layer it's also not attached, and we can see the rupture in the center. I injected a 20% SF6 gas bubble in the anterior chamber, and here we can see a picture of the eye on day 3 and also an OCT. When we can see that the place with the bubble it's attached, but in the inferior part of the cornea, the duas layer and decimate's membrane, it's detached. 10 days after SF6 bubble, patient says that vision is very blurry again, it's foggy, and at the slit lamp I can see again that duas and decimates are detached, and we have again a triple anterior chamber. This is to be continued. I'm very interested in hearing all your opinion and what. Thank you very much for your kind attention.
May I?
Yes, please, Prof.
So I think the problem here is there's residual viscoelastic. When the predesmate layer tore, very fortunately the DM didn't tear, and you have viscoelastic between the predesmate layer and descemet's membrane, which is then coming out, and you find some of it is seeping beyond the edges of the tear onto the plane between the predesmate layer and the back of the new cornea. We have seen this happen where viscoelastic has been used and not fully removed. It can stay back for a long period of time. And sometimes it might be in the stroma, where if you didn't get a bubble and then you do manual dissection, you leave some behind in the stroma, it takes a long, long time to go away. So that's a possibility why this is taking so long to reattach and not attaching as well it should if it was just pure aqueous over there.
Yes, I completely agree. Even that's the advice that I gave her, that it's just not putting a gas bubble in the AC that's going to attach this. You might have to break some of the sutures, lift up the graft, put in a complete air fill, and then give a wash so that the trapped viscoelastic which is there, unless that is evacuated, you will not be able to make this settle down. It'll keep recurring.
Also depends on which viscoelastic she used.
True.
If it was a cohesive one, it would come out easily. If it's a dispersive one, it'll take a long time. Eventually it will go, but it will take a while. Yeah.
Yeah. So I think this is an important point to understand, that viscoelastic can be used in bulk surgery, but if you don't put it at the right plane, sometimes you can have this kind of problem. And also, unlike an air bubble where you might feel some resistance at the end, knowing that this is the end point, visco being denser, sometimes you don't get that feel in your hand, and you can very easily overinflate. And being denser, you can break it as well. Maybe the scarring that was there from the infective keratitis would have also induced some changes in the pre-Decimus layer, making that part little inelastic. And that's why you got like a mixed bubble where it broke the pre-Decimus layer and you got the type 2 bubble or with the visco.
Also, one thing which is very important with visco bubbles is that the more anterior you are, the less likely you are to succeed, and you are at risk of causing an intrastromal bubble. We published this in the experimental eyes. When you get an intrastromal bubble, it there's a saying in English that if it talks like a duck and it walks like a duck, it must be a duck. This one looks like a type 1, feels like a type 1, but is not a type 1.
Not a type.
It's an intrastromal bubble. You can cut it, take it, everything looks fair. You do OCT next day, you got a variable amount of stromal thickness that is left. You never get intrastromal bubbles with air, only
True.
with viscoelastic. But the trick with viscoelastic is to be deep. So she debulked the top, then she went. So automatically she's making sure she's in a deeper plane, and therefore she reached the, and you can get a nice type 1 bubble, but you have to be very deep with your cannula. And that is an important thing to keep in mind.
But excellent documentation. I would see the OCT image is very beautiful, showing the attachment of the decimets and showing the pre-Decimus layer or the Duas layer, which is also broken. And
yes, that was very nice when she showed the slit. So, I mean, we are understanding these things much better now. Therefore, we're understanding what's happening. Otherwise,
Dennis, any questions that you want to ask?
Hello. I don't know if you can hear me because I'm in a resort, but
We can hear you.
no questions. I guess I just have to go in again and try to remove the remaining viscoelastic, and well, do as you said, because if not, maybe it's never going to attach, or I don't know how much long it will take for the decimets and Dua to attach. Thank you very much for your insights. I appreciate that.
but there's one point, as Rajesh also mentioned, that if you're going to be with a very fragile Descemet's membrane, it is intrinsically, not because what you do, it's just fragile Descemet's membrane, full stop. So what you do is you do a paracentesis, release as much aqueous as you can, so the Descemet's membrane is very flaccid, right? Once you've released aqueous, then you can just wash without trying to go between Descemet's and the pre-Descemet's layer. Then you put air, it'll squeeze out some of the viscoelastic. But again, too much air can cause it to burst. So you have to make sure that you don't put too much air, or just loosen the sutures, put in air so that you squeeze out the viscoelastic between Descemet's membrane and the Duas layer. Then you take off the full top and wash, because that way you have less risk of bursting it or damaging it with a probe, with a cannula or whatever. Or just wash with a jet of water. Just a stream of water. You can just use the water cannula and the jet of water. You can wash it with that, but don't touch it with an instrument. But keep the AC very flaccid, very soft, and that way it won't burst.
All right. Thank you very much.
Thank you.
Okay. Thank you for that interesting case, Dr. Fogla. Any other comments from Professor Radhika Tandon, Professor Bhavna Sharma, even Dr. Manoj Mathur has joined, I believe.
I would say that we have also published this triple anterior chamber, and it was a retained viscoelastic. What we did was that just release the suture. I didn't try to wash the interface directly. We very carefully saw preoperatively which was the pocket where there was the retained decimets. The retained viscoelastic, and then, as Dr. Dua said, injected air in the AC, and with the loose suture, most of the viscoelastic just melted itself out. It's published in the American Journal of Ophthalmology, triple anterior chamber after DAL.
I think if you have access to an intra-op OCT, managing this would be quite, it will definitely be helpful. This is one scenario where intra-op OCT would help when you are doing this.
Okay, great. I think we've overshot the time quite a bit, so I think we should wrap up now and we can have rest of the discussions offline maybe. So I would like to thank Professor Dua for the excellent masterclass. Although we did overshoot time, I believe that it was a good use of time. So that's why I was not stopping anybody. So, but some very interesting discussions and good learning points. And I hope that all of us had a lot of benefit attending this masterclass, and so does everybody else who watches it later on. Thank you very much, and good night, everybody, whoever has their video on. Thank you.
Thank you.
Thank you.
Bye.
Thank you. Thank you, Prof.
Bye-bye. No,
Bye.
no.